So welcome everyone. Good morning, good afternoon, and good evening, wherever you are in the world. And welcome to this, our fourth webinar on our clinical education series. And today it's going to be about psychosocial in situations of trauma and humanitarian crises. My name is Joan Marsden. I'm speaking to you from Bloemfontein in the center of South Africa, and I'm on the executive committee of Palchase. And it's really good to have other members of the executive committee here with us today. Erin, that you've heard from, Megan from Canada, Catherine from Geneva, and one of our main speakers, Father Rick Bauer, who's in the USA from DC. And so you're all very welcome. I hope that you've all had the opportunity to become members of Palchase, because I think if we look at the world around us with what is happening, not only the conflicts in so many different places and the tragedies that are happening, but also the impact of climate change and poverty. And I think we realize that issues around psychosocial and spiritual care and trauma are just really enormous. And so we're really looking forward today to hearing our two main speakers and our panelists. So what I'm going to do is I'll just introduce the speakers before they present, and then when the panel at the end of the speakers, I will then introduce the panelists. So our first panelist today is Father Rick Bauer. Father Rick is a Catholic priest, he is a social worker, and he is also a board-certified chaplain. And he's been working in the field of hospice and palliative care since 1982. And I think, Father Rick, that was when the AIDS pandemic was really hitting the world. And so he's been involved in faith-based and public health delivery systems. And we're very pleased to say he was here in East and Southern Africa for 25 years. So he has a deep understanding of what happens in developing countries as well. So after that time, he's now at the George Washington Institute for Spirituality and Health, GWISH. And he's also a faculty member for the School of Medicine and Health Sciences. And he provides clinical chaplaincy to the George Washington University Hospital and Children's National Hospital, both level 1 trauma centers. And so without any ado, I'm going to ask Father Rick to speak to us. And for those who've just arrived, would you please just put your name and where you come from in the chat, and you are very welcome.
And again, thank you so much. I'm going to try to share my screen now. And there we go. We're good?
Looks great.
Okay, thank you so much. And thank you so much for this invitation to speak. I know I've got 20 minutes and I'm going to keep to the time. Not really being able to teach you how to do the spiritual domain of palliative care, but to make you hungry for more information. And I will make these slides available and some more resources available. So some key concepts, and I'm going to review, I've taught this before, but I think it's important just to remind us again that when we're looking at spiritual care, that spirituality and religion are related. And for many people, they're very closely related. But for increasing numbers of people across the globe, but especially I think in Western countries, they're very different and they're very succinct. However, caring for that human spirit is absolutely essential for holistic patient care. And so often in palliative care, and Joan knows that, Joan was always the one that said, what about the children? What about the children? And I'm still doing that. But so often I go to palliative care meetings and we're talking about access to analgesics, hugely important, huge important issue. But if we're not taking care of all four domains, the physical, the psychological, the social, and the spiritual, I just want to say we're not doing palliative care. We can be doing great physical pain relief, which is very important, but we're not doing palliative care. And in palliative care, both children and adults have to attribute some meaning to why this is happening. I loved my time in Africa, and I've done some work in Asia and Latin America, that all these cultural beliefs that often include different spiritual and religious and cultural all weave together in very complex ways around the meaning of a life-threatening illness. If you hear nothing else I say today, hear this statement. You do not have to have the answers. In fact, pat answers are rarely helpful. What we are called as palliative care people is to be present to suffering, to be present. That's not to say that we want to alleviate suffering, but pat answers like, well, God never gives you more than you can handle, or God must have a reason for this, are never and very rarely helpful to people. But being with people in their trauma, with spiritual care in trauma settings, we want to provide comfort, big words, without re-traumatizing. We want to be in the presence of suffering. And as my first mentor in Africa said, stand in the face of horror and not run away is often one of the important aspects of our palliative care in humanitarian situations. We talk about this generalist specialist model, and many of you I know are in master's programs getting more education to become palliative care clinicians, and that is so brilliant. Every one of us on the team needs to be able to be a generalist. And so I can see Joan Marston and when I got to Africa and I first started learning about African palliative care, Joan taught me how to do a physical pain. She taught me those little smiley faces on a scale of 1 to 10, 1 being no pain, 10 being the worst pain of your life. How are you feeling today? I can do that. But as a chaplain, that's the limit. I'm a generalist in physical assessment. Then I have to bring it to Joan and to our physicians and our clinical officers. So in the same way, every one of us needs to become a generalist in looking at spiritual pain and spiritual distress. And then there is additional training to become that specialist. So here is kind of the definition that we are globally using throughout kind of the world. This is a consensus definition, and most of the research is now quoting this 2014 definition. So when we're talking about spiritual care, what do we mean by this? What do we mean by spirituality? Well, it's a dynamic, it changes. It's intrinsic, it's part of everyone, of how we seek ultimate meaning, purpose, transcendentness, and experience relationships to self, family, others, community, society, nature, and the significant or sacred. Spirituality is expressed through beliefs and values and traditions that can have religious undertones, belief in Allah, belief in God, belief in karma. It may also have existential beliefs of trying to figure out how I fit into the universe. So we're talking about the most broad terms with spirituality. I don't know why this will go. So spiritual distress, then, this is as the clinician, and Joan knows how to assess physical pain. We're also looking at how do we assess spiritual distress? And it's that inability to experience and integrate meaning and purpose in life through that connectedness with self, others, art, music, literature, nature, and or a power greater than oneself. One of my favorite quotes, suffering is not a question that demands an answer. It is not a problem that requires a solution. It's a mystery that demands our presence. And I look right now, and I don't want to, speak for Alexandra in Ukraine or our colleagues in Gaza, but to try to make sense of the horror of these two things. I don't know how to do that. I do not have a spiritual answer of why this is happening. Doesn't mean we work to stop this, but it also means as palliative care clinicians in trauma settings, we choose not to run away from this. And we choose not to run away from the incredible pain that our patients are experiencing. So one definition of self-care, and this is actually from our Scottish colleagues from the Scottish National Health Service. It's that care which recognizes and responds to the needs of the human spirit when faced with trauma, ill health, sadness. It can include that need for meaning, for self-worth, to express oneself. It may be faith or religious support, or rites, or prayers, or rituals, or simply that compassionate, sensitive listener. Spiritual care begins when we encourage that human contact and that compassionate relationship, and it moves in whatever direction the patient needs it to move in. So this is not about what I believe or my religious or spiritual beliefs. Palliative care is always patient-centered care. It means that deep listening to that inner story. It means listening to what is said, and as we know in palliative care, it means listening to what is not being said. It means all of us need to listen for those spiritual terms, themes, how people are searching for meaning. What is their source of hope? What keeps you going on? How do they experience being connected to themselves, to others, to nature, or to God, a power greater than myself? How do we go beyond ourselves to make sense of what is happening? It means listening and identifying to spiritual resources of strength. And this is where my social work background really comes in. So often as clinicians, we're trained to look for problems. We're trained to look for deficits. We also always need to look for spiritual strengths. And then it's making that connection. How does this person view their spirituality with their health and their well-being? So these are two slides that we could go over, a lot at separate lectures in and of themselves. But again, when I'm looking at spiritual care, some of the domains for adults that I'm looking at, how does this person experience connection? Are there spiritual strengths of love, belonging to the significant or sacred, to other people? Is there distress over grief and loss? And I can't even wrap my head around the unbelievable, unprecedented loss right now in Gaza. I don't know how to answer how we deal with that other than not running away. Does this person feel abandoned by God? What is their sense of peace? And I often ask that question, what brings you peace? Are you at peace? What about meaning and purpose and just being present to that deep existential question? Why is this happening to me? I want to say children also have spiritual needs and experience spiritual distress. And so some of the things I look at when I work with children from the NICU to teenage, to young adults, how do they experience love and faith or a worldview, belief in something greater than myself? How do they experience hope in the presence of their illness? And especially in humanitarian disasters, when children may have lost their families, they may be unaccompanied minors. In Gaza, the numbers of children that have lost parents now. This was so true during the HIV years, the trauma of, I hated the term, the AIDS orphans, but the numbers of children that were in extended families caused a real spiritual distress. How do children express beauty? So we always want to be looking at both spiritual strengths and spiritual distress. Disaster spiritual care is that process by individuals, families, and communities affected by disaster draw upon their heritage, their traditions, their cultures of faith, hope, and community as a form of strength that can bolster the recovery process. This is not to deny the horrible pain and the tragedy of these disasters, but it is to try to find what gives us hope in a time that seems almost hopeless. We do disaster spiritual care to again find that sense of meaning, purpose, and connectedness, because we now know, and we've got some good data, that disasters and humanitarian crises disrupt people's spiritual lives, their beliefs, and their practices. It may destroy their temples, their mosques, their churches, where they traditionally got spiritual support. And again, I go back to our WHA definition, and we are now at the 10th anniversary of this, that it's that early identification and correct assessment of pain and other problems, whether physical, psychosocial, or spiritual. We must assess for that spiritual pain. Disaster spiritual care is unique. The disaster spiritual care provider really engages in a concentrated, it's often very intense, both for the provider and for the patient. It's very different than kind of the day-to-day life where the local pastor, imam, priest, pastor might visit a parishioner and how are you doing? I never ask somebody in the midst of a disaster, how are you doing? Because we know that I don't want to re-traumatize them. And the severity of the disaster means that we need to get better trained at this. I will be very honest with you. The field of spiritual care and palliative care, we are still at the state of evidence-informed. We're getting better at some evidence-based interventions, particularly around communication models. Disaster spiritual care is even further back, but we're getting some consensus, we're getting some guidelines, most of it right now coming from the US, but I think we have tremendous opportunities now to build on this knowledge base from around the world. The goals of disaster spiritual care: to stabilize after the initial impact of trauma, the reduction of symptoms, the promotion of resilience, and ultimately a return to adaptive functioning and referral. This gets, again, this is up here knowledge, the head knowledge. This, makes really good sense if it's a natural disaster, a bombing, an earthquake. When we have the sustained war, we're going to need new models to add to this. because this is not simple and this is not easy. I don't want to take away from what Alexandra is going to talk about, but I love this model of psychological first aid. And I want to do SFA, spiritual first aid, but we're not there yet. But I love this model because I think the model of psychological first aid has a lot of application to what we can do to help people with the human spirit. I know I just got a few minutes left, so I want to now look at caring for the caregiver. And another favorite quote of mine is that the expectation that we can be immersed in suffering and loss and not be touched by it is as unrealistic as being able to walk through water and not getting wet. If you are providing disaster palliative care, if you are providing palliative care in a war zone, in a natural disaster, there has to be a concrete plan for caring for yourself. That could be participation in an organized religion. It could be meditation, other forms of mindfulness, regularly connecting to that deepest part of yourself, acknowledging and reflecting on what gives you, not your patient, what gives you meaning and purpose and connectedness. How do you connect with the universe or a power greater than yourselves? Sometimes people say to me, oh, that sounds, taking care of yourself is selfish. Well, all of the world religions talk about the importance of self-care, whether it's Christianity and Matthew and Ephesians, the Islamic tradition of praying 5 times a day, the Buddhist and Hindu traditions, and a growing body of evidence for those who practice mindfulness-based practices have a resiliency. And so we need a self-care plan. And I'm to the belief you've got to, if you're in a disaster, you've got to have a daily self-care plan of how you take care of your body, mind, spirit, emotions, and relationship, what your top coping strategies are to deal with horror, and things that are helpful, what you need to do every day, and things that you know that may be tempting to avoid, that are not helpful for your own spiritual health. Again, I'm willing to send these out and provide some good articles. Disaster spiritual care is new. We're growing the evidence base, but it's still evidence-informed care and a lot of consensus work. There is my email, and I'm more than willing to share these slides and engage in a robust conversation. And I know we have some panelists to get this conversation going. And so with that, asante sana, gracias, merci, and thank you.
Thank you so much, Father Rick. And there are so many questions that I have in my mind. So please, as you think of questions, would you put them in the chat so that we can be sure to respond to them, either in discussion or through the chat or later on through emails. And just to say that recordings will be made or are being made, and these will go up on the Palchase website in the not too distant future. So if you want to refer back to anything that Father Rick has said or to look at those references, they will be on the Palchase website, which is palchase.org. And so now I have great pleasure in introducing Alexandra Shimanova from Ukraine. She is a Ukrainian Jungian analytical psychologist and a body-orientated therapist. She's also the co-founder of the NGO Psychology Center, The Soul, which is based in Kyiv. And they have been doing tremendous work in outreach not only into Ukraine, but also to those Ukrainians who are outside the country as well. And I think that the work that they are doing is actually something that we all need to learn from. And so with that, Alexandra, I'm going to hand over to you for your presentation. And please, everyone, just put your questions in the chat so that we can respond to them. So thank you, Father Rick, and over to you, Alexandra.
Hello, everyone. Thank you very much, dear John, for inviting me to such an important event, and all the purchase organizers and executives. Honored to see their colleagues from related specialties who are serving and taking care about people from the bottom of their hearts. So my presentation is aimed to answer the question, what is psychotherapy and counseling of humanitarian setting? And I would like to highlight exactly some main pillars of the latest ones. Those statements are based on my individual experience as a therapist and also on the activities of the NGO Ukrainian Psychology Center The Soul before the war started in Ukraine and through the last almost 2 years. Few words about me. I have been working as a therapist since 2011, initially with children with autism and their families, and then in regular Ukrainian primary and middle school classes. Then conducted private practice and group therapy work with people during the peaceful time. With my colleagues from Kiev, we created the Psychology Center The Soul just 1 year before war started. We held various events aimed to raise psychological awareness and establish the key role of mental health in general people well-being. When the war started, we reorganized into an NGO and launched the Crisis Center, providing urgent psychological help for those who needed it, and continuing to do it until now. The definition of humanitarian setting includes events which caused the critical threat of health, safety, security, and well-being of the community and large group of people. That is the definition according to the Interagency Working Group of Reproductive Health and Crisis 2010. If we take a quick look on the map of the whole world right now, we can sigh and become short of breath, starting to get consciousness about the fact that now the bigger part of the world is involved in the humanitarian crisis. That is why the world feels so heavy today, literally. And this is not something new. According to the data of Hungarian political scientist István Kende, through 1945-1986, there were only 26 days without war. Another historical investigation said that this is if you sum up the duration of all the wars in the earth, then the period of time for 6,000 years of civilization when there was no war equaled only 3 months. According to the country where I am from, this humanitarian crisis is unfortunately well known also. For the past couple of centuries, Ukraine was divided between different countries, and the previous 100 years was under Soviet Union occupation, faced artificial famine during Stalin's regime, and finally became independent, and from this time going on to struggle for its right to at least be alive. Just feel, at the beginning of 90s, our population was 52 million people. Right now, within the country borders, there are barely 26 million. Forcibly moved abroad approximately 8 million people. Inside the country, people who had lost their homes and needed to change their place of living are almost 7 million. Those who are in the country now face everyday threats, mortal threat. Every day could be your last. Right now, that is the 700th day of full-scale war. Remind you that it started much earlier in 2014 from the Crimea Peninsula annexation. Here on the slide, you can see some key facts according to the internal situation of the country. And I accompany it by the words of Ukrainian medicine practitioner Natalia Nikolaeva, who somehow remade the famous words of Viktor Frankl and says, "The first ones who've been broken are frightened by the dark. They were followed by those who lost their light." So first we'll start at, so the first main important statement of the psychotherapy and counseling in the times of humanitarian crisis is how to keep on going this light by oneself, the caring practitioners, and help to do the same for people. First, we'll start at least to try to answer this question. Just try, because I believe that is not true and unchangeable. It's completely vivid and dynamic process of constant losing and finding of those answers, attempts to find them. We should look at this scarce mapping of those psychological struggles people have right now. And those are two of segments. They are different for those who are currently in Ukraine and those who are outside the country. But somewhere in the deep, in center, the suffering is the same. Complete apathy, lack of energy and resources, dead-end feeling, hardness in making decisions. All those might be hidden in extra high chaotic activity just not to stay alone with the painful feelings, which are unprocessed losses of themselves, homes, beloved ones, past lives. There is also suppressed anger, identity loss, absence of future and hope. I am adding to this list every day while I am working with people. And of course, we can feel enormously this huge change in counseling and psychotherapy settings meanwhile, peaceful times and during the situation of mortal threat every day. Before it seemed to us that we had all the time of being, now every minute is priceless. So it changes the approach. More and more people need immediate relief instead of long time reflections. And if we concentrate more before on growth and development, now our focus of attention is on survival mode and the attempts to preserve at least the life and energy sources, which are constantly in the background of anxiety and depression. During the last half of year, we conducted a series of therapeutic online groups, events, and open on-air meetings dedicated to this ability of keeping the light. I named the light here like the ability to continue striving for life again and again. Nevertheless, it's happening in this life. And in our therapeutic activities, we were following this four-quadrant model conception developed by Elizabeth Kubler-Ross. It includes body, soul, mind, and heart components. And the pillars which I'm starting to present you right now belong to each one of them. The first one, pillar of psychotherapy and counseling through the humanitarian crisis times, touches upon the mind component of the quadrant model and assumes the reality principle. It's about facing and naming the reality which happens right here and now, naming what happens with the true words, not hiding from the reality. We conducted the therapy groups with the circles of sharing where people keep on retelling what had happened to them. The main principle of those meetings was the famous quote of Jung, "I am not what happened to me, I am what I choose to become." Then we are moving to body component quadrant. It includes that every therapy meeting with the person in the humanitarian settings must include the body work. Our aim is to return the person into their own bodies, because in the moments of critical threat, we all know this feeling when it seems that the soul flies away from the body. The most favorite techniques are breathing ones, standard to concentrate only on the process of breathing. The dynamic moves, the favorite of the children is wet puppy when you are shivering intentionally with all of your body. And supportive moves such as hugs, for example, yoga and physical training, running, jogging, power exercises also improve their effectiveness. Third pillar touches again with the mind component and the sense that we intentionally preoccupy our mind not with overthinking and prediction of various catastrophes, but with the differentiation. We were working with people on this awareness of what depends on them and what is not, pointing their efforts on everyday small attempts of living to clean the house, make the bed, prepare some food, take the bus if possible, help those people who are more in need than they are. All this returns the power into people's hands, which is constantly grabbed from them. Fourth, and maybe the most favorite for me pillar, touches on the power of heart. It's about our emotional connections and the sense of belonging. When we gather into groups, speak to each other, share our bads and goods, and sing songs, we become more resilient and strong. Here is the video of the song we were singing with the children, the Ukrainian one. For the lack of time, you can see it then in the presentation. And speaking of songs occurred while making this list of pillars unexpectedly important, and it touches on the very important spiritual component of the Elizabeth Kubler-Ross quadrant model. This is about roots and belonging to these roots, and it can be very important to every nation that is facing the humanitarian crisis. It appeared very effective in the process of taking care and healing constantly to provide people with key historical facts, authentic culture such as folklore music, paintings, art, cinema, and poetry. People started to feel themselves very deeply supported by the power of all those ancestors who lived before and created this culture. This all in complex gives the people the feeling of something bigger than they are, and accordingly more powerful, but not victimized as it feels under constant threat and terror. And here are some examples of the pieces of art we are constantly sharing and discussing with people. You can concentrate on your feelings right now and just let them make their healing work upon you. Just few examples. Our Ukrainian paintings and pieces of art. We are constantly showing and discuss it with people and bring it them more powerful. And this is Ukrainian song, which I do sure that every one of you knows some notes. I will make a pause here. You can listen it also. And in the sixth pillar touches, I guess, both the spiritual and emotional components, stand upon the crucial role in healing and supporting the life process of grief and bereavement. This is an example of how we can go through those unbearable hard feelings by means and help of pieces of art again. Trauma-informed therapy asserts that we can't touch painful issues directly, but only through the safe lenses. Films, cartoons, paintings, poetry could be those helpful facilitators during the process. You can also see this cartoon then in presentation. And the last but maybe we should put it even first to this list, is the pillar which combines all the components of quadrant, is the pillar of mutual help and support. The only way to keep on light and continue to stay on the side of life is what you are seeing here. One of the most suffering countries and nations in the world, the Israeli psychological specialists say that people who from the first moments of the hard times were involved in helping and taking care for others show the less symptoms of trauma and post-traumatic disorders. So it's impossible to live further and cope without this waving basket of such communities as ours, as Paul Chase, such meetings that are happening right now. And it makes a big impact in the matter of building the counterweight to everything that is going on right now in the world. So thank you for the very bottom of my heart. And thank you for your attention. And here are some slides for our contact with our organization, with our programs that we provide, and our activities of our center. Thank you very much.
Thank you so much, Alexandra. I think from your presentation, it really shows us that there is something that can be done. And there are ways of reaching out and helping. And so we're going to go into our panel discussion, and I'd like to introduce our two panelists to you now. The first one is Jenny Hunt. Now, Jenny lives in Zimbabwe. She is a qualified social worker, and she specialized in palliative care and bereavement. And she has a very comprehensive experience working in generic palliative care and social work, but also outreach into humanitarian settings, where she has been teaching both in Bangladesh and in Gaza. Jenny, I know you have a bit of unstable network, and as someone who's just in the middle of a power outage, living and working in Africa can be a challenge. But Jenny has done a tremendous amount for the development of bereavement care throughout Africa. And then together with Jenny, we have Chantal Kadra from Lebanon, who is a licensed clinical psychologist with over 10 years of experience in the field. And I'm not going into in depth in her CV, which you'll be able to read on our website, but she is involved with Sun at Home Hospice Care, where they provide palliative and hospice care to patients, to caregivers and family members, and holistic care. And so to our two psychologists and to our social worker and our spiritual carer, we'd like to just give you a few questions that perhaps you could respond to. And so Jenny and Chantal, I wonder what you think, that given that humanitarian crises are often so unstable and chaotic, is it really realistic to think that we can do spiritual and psychosocial care? How realistic is it? And what can be done apart from the wonderful work that we've seen from the soul? So Jenny and Chantal, would you like to respond to that?
I'm happy to take a first stab at that. Yes, I absolutely believe that this is possible. And my experience is that it's very often the only kind of help that can often be provided. Because in my experience, there's very often no resources, there's no medication, there's no emergency services, there's none of that traditional palliative care, as in, all the kind of the morphine being available and everything else. So very often what we're faced with in these situations is that you can only use yourself as a palliative care compassionate listener. And that's very often the only resource that's going to be available, certainly in the immediate time. So I think there's a little bit of, we need to sort of differentiate, I think, between the immediacy of a crisis and the long term. And I think that Alexandra's wonderful presentation, I have to say, thoroughly enjoyed it. But it talks very much to, the ongoing crises that people who are then in a place where they can have that kind of support. But very often what we're faced with immediately is total chaos, ruin, destruction, screaming, shout, just awful. But I do believe that in those situations, that just being there, I take Father Rick's point about this need to just be present when there's very little else that can be done. This ability to do this deep listening, this connection with a family, with a child, whoever it might be, that's very often the only thing we can do. So rather than you're sort of putting all the medical side on a pedestal, which is often what we do, and of course that is a real priority, but where that is missing immediately, this is what we can do. Psychosocial care and spiritual compassion is possibly the only thing we can do for quite a while.
Thank you, Jenny. Thanks so much. And Chantal, I wonder if you would like to add to that, and perhaps you could help us look at what might be the priorities and the limitations to providing spiritual and psychosocial care in these humanitarian crises.
Yes, definitely. Jennifer expressed it very well in time of crisis and when things are chaotic. Thank you so much, Jennifer, with all the experience that you have on the ground. But at the same time, I think there is different levels for the interventions, and maybe we need to be prepared for a crisis and to manage in time of crisis, at the same time to prepare for a long time and post-crisis. So there is a lot of barriers, of course, especially with the lack of resources on the ground. So the resources, maybe Kamena, the language barrier is crucial in this time, especially that professionals are mostly from outside the country, and there is not training for the civilians in the country. Yeah.
Thank you, Chantal. And I think that's something that you've identified, that we really and truly, it's the preparation in the country before the disaster happens, because during the humanitarian crisis, then training of the community would actually be a very low priority. And so I think we're seeing, if I look at Alexandra, your presentation, where in Ukraine there was a good development of palliative care. So when the war happened, it has continued, and it has grown in some ways, although many of the patients have gone out. But I also, to our panelists and of course also to Father Rick and to Alexandra, what about the huge bereavement needs that are going to exist at the moment, but are going to be there for many years to come? Have you any thoughts on what the approach should be to that? And Jenny, I know that you have developed your 9-step model.
Yeah, just briefly, because I'd love to hear the thoughts of others, but just briefly, really the 9-cell model just draws on the existing knowledge and experience of people within that culture, because one needs to be so culturally sensitive and draw on the strengths of that community. And that's what that model does. And it really is just a process of raising awareness in any kind of community. So in times of peace and calm, that would be the ideal, is to basically equip the country with that kind of thing. But just very briefly, the grief and bereavement, when it's a moment of crisis and it's all happening, it's inappropriate to be addressing that right there and then. This is the longer term, as you indicate, Joan. But yes, being able to put together the resources to be able to cope with it, because it takes a very, very long time.
Yes, it is going to be a great channel. And Father Rick, there's a question here about how often in these situations that people blame God. There's a very real anger, and how does one address that? You can understand when you're home, you've lost your home, your children have perhaps been killed. How do you address that anger towards God, or however you name this greater spirit?
Absolutely. It's the difference between, I say, getting it real or getting it right. Getting it real is much more important in this situation. And the real thing, if somebody is angry at God, that's a good thing. If they're religious and they're angry at God, sometimes then they feel guilt. So I often say, we only get angry at things we love. If I don't care about you, I usually don't get angry with you. And that sometimes can help the religious person deal with being so angry at God of why this has happened. I'm also, my kind of go-to phrase, I do not give those pat answers. And when someone looks at me in the eye and says, why is God doing this? I hold their hands, look at them in the eye and say, I don't know. But I do believe God will be with us, and I will be with us as we, if that's true, but I will be with you as we work through this. I just think we're too afraid of saying, I don't know. We have limits to our knowledge, and that's one of the things.
Yeah.
I liked what somebody said, how do we do this? Can we do this in the midst? And just to add what Jenny and Chantel were saying, sometimes I think and I try to teach this when I teach my medical students, they are so busy firing off questions, getting through their assessments, and you have to do that in a trauma situations. Thank God you're doing this in a trauma situations, and checking the airways and doing the breathe and all the stuff you do. I get it. But sometimes what palliative care can do is just to create those moments in the middle of chaos to create an oasis and an island of serenity, even if it's for a minute. That can be healing. Don't underestimate. This is not quantity of being present, it's quality.
That compassionate presence that brings calm. Yeah. And there was another question, and Alexandra, it comes from Nala Gaffer, who is from Sudan, and so she's experienced this. And she asks about what happens when crises are added to previous crises and they increase with the passage of time. What could be the negative psychological outcomes of that? And I think with your experience in Ukraine, where these attacks have been and wars have been going on for much longer than the 2 years, that you might have some way of commenting on that.
Yes, thank you for the question. And firstly, I add a few words about grief and bereavement. And surprisingly, what I am facing in this process right now is the very helpful tool of social media, of the Facebook, Instagram, Telegram groups, various chats. It occurred to be very helpful because for us Ukrainians, my Facebook feed now it's a whole obituary. Every day there are some posts of the people whom I even don't know, about people who were died, whom they lost. And almost every day they are writing something about them, they're sharing their memories, and thousands of people are commenting this. So people are uniting in this pain. And it transforms the pain into the huge impulse of light and of light, really. So, and this is according to this question I'm continuing, that this amount, like adding sum of suffers, when we are using the Jungian terminology, what is hiding in the shadow? In the shadow, hiding, yes, echoing the Rick's words, we can be angry only on those whom we love, and we feel so much pain only about whom we love. So after this wave and first level of pain and anger, the huge impulse and waves of love occurring. So what we are doing, we are like mining, digging up those layers of those unbearable feelings to reach those zones of love and compassion we still are having to each other through these times. Thank you.
Thank you, Alexandra. I think that is such an important issue that you're speaking about. Is it almost you form a community crossing borders, and you, even for those of us who've never met in person, you actually are forming bonds. And how often people, especially in Ukraine, have said to me, it's just enough to know that you're there and that you're connected. And I think that is the use of social media, which we forget about, but is such an important part of life and of connection. And I think, Rick, it also links to spirituality, doesn't it? It's a form of connection with others. And now I'm just going to see if there are any more questions here. I'd just like to say thank you to Serene Ali, who's our intern now from Canada. Have you picked up any other questions that are actually in the chat, Serene?
Yes, Joanne, there's just one more left. This is from Ishita Sarkar, and her question is, what could be the initial questions that could be asked in order to initiate spiritual care conversations? Thank you.
So, Father Rick, over to you.
Depends on the context. I mean, this is, again, a whole other lecture. How do we do spiritual distress screening, history, assessment, you know? Come to one of our iSpec courses and we can teach you that. Sometimes my fast definition, you know, that we have some research on is, are you at peace? You know, if you're in a war situation, that may be a dumb question. What brings you peace? What brings you hope in the midst of all of this? How do you continue on? If it's appropriate, depending on the person, I might ask, do you have a spiritual or religious tradition that was helpful for you? So that's kind of where I start, and just see where the answers go, to make sure it's patient-centered. So I'm not putting my spiritual and religious beliefs on this person.
Thanks
And
so much,
Joan,
Father.
Joan, I think from just the psychosocial side also, again, in the midst of the sort of the trauma of it all, the drama, you know, just simple questions, you know, like, what matters most to you right now?
Yes.
What do I need to know about you right now? Because, you know, one takes the context of very little time, the urgency, maybe, you know, just the physical situation of being breathless and dust everywhere, whatever it might be. So those sorts of very direct yet sensitive questions, I think, are some kind of introduction to the conversation, whether it's just the sort of emotional stuff or the spiritual stuff. Very simple, but pointed.
Thank you, Jenny. And I see that Malinga Piramal has posted, I believe that grief is a long-term, oops, sorry, I'm losing it now. Let me find it again. Where are we? Sorry, I had it here. I'm sorry, I seem to have lost a long-term process, and just listening or accompanying and being empathetic is essential. And I see there are some more questions that have come through as well. Serene, would you like to read them through?
All the others are just comments. Joanne Pranab just commented saying, no word is apt to analyze the webinar. Oh, so he's just talking about the webinar. Beyond any appreciation, he's just thanking the panel for sharing it in a very lucid way. the question.
That's wonderful. Thank you so much. So just to say to you that these recordings will be available on our website. If you have any questions that we can forward to the panelists, please do feel free either to contact Palchase at info@palchase.org or to contact directly the panelists whose emails you will see on the website. And so I want to say a huge thank you to Father Rick, to
And
Alexandra.
Erin, wait, Joan, Erin
Yeah?
has her hand up.
Uh-huh.
Yeah, Joan, I'm so sorry. And I feel like my question now may be anticlimactic as you end the webinar, but I do have a question for Chantel. I
Okay,
probably should
yes.
put it in the chat. But I'm really curious as to in many of the conflicts that we are facing, they are protracted. We have people joining Palchase from places where conflicts are ongoing. Natural disasters continue to happen in similar places. Do you find that people who've experienced trauma and then are potentially diagnosed with a serious illness, are they able to get access to deal with some of the mental health effects of the conflict? I'm particularly thinking of some of our families in Kenya who have dealt with a conflict in Somalia for many, many years, and now they are continuing to grow as a family and are faced then with a serious illness. Do things come up during those times, and how can we help people like that? Is medication a good idea? Is accessing psychologists, psychiatrists? How do we advise in those situations?
Okay. It depends on the level of the psychiatric problem, because in the continuum of the stress, to have a psychiatric problem, the response will be different from a person to another. So if it's anxiety, depression, or even post-traumatic disorder, it can be helped by primary journalist, as Father Rick said before. It's compassion listening, reassess their own coping strategies, and give them a safe space for them to express themselves. On another hand, people with severe mental health illnesses, the best way to go with is the medication. So a psychiatrist can be more helpful than a psychologist at first. So the first line of intervention will be with a psychiatrist.
Mhm.
I don't know if I
Thank you.
answered your question, Erin.
And I know we're getting on the time to add to Erin. I think one of the things we certainly learned in the early years of the HIV pandemic, when there was nothing, no medicine, no treatment, is creating opportunities for service. Now, if somebody has a significant mental illness, but for many people, just to be able to give back once they've been stabilized in the crisis, to be able to help the new refugees that are coming in. I look at parents at the Children's Hospital that have just lost a baby. Yeah, I'm pretty good at doing things, but let me tell you, a mother that has lost a child is and she's now helping the new mother that lost a child to create those opportunities to be of service can be healing for everyone in the community in these prolonged crises.
Community approach, yes, definitely.
Yeah. Mm.
Yeah.
Thank you both for that. Erin, do you want to comment on the response?
Yeah, thanks so much. I think because we are a global network, we're growing. I head up the communication team, and it's so exciting. We're 500 plus members now. I think when we gather together in these moments, it can be tricky because we have people working in many different settings. We have people fleeing from their current workplace that are professionals in palliative care. We have people that are going into conflict settings to provide care. And I think this idea that because when conflicts happen, we all are impacted. I mean, the fact that we as professionals have secondary trauma when a conflict happens, I mean, these are all things that we probably 20 years ago didn't really talk about. And I do think that people like MSF, IRC, ICRC, some of the very big humanitarian players are beginning to acknowledge that mental health is an issue, and their beneficiaries of their humanitarian responses are really impacted. And we're starting to grow in terms of palliative care. So we may be able to identify some of these patients that could use specialized support, at least in the mental health. And I think we know that it can be a lifelong challenge having depression, post-traumatic stress disorder. And I think we as a group can find ways to advocate for these patients as well. I know there's many places where we don't have resources, especially for mental health, but if you do, and you know in your area, you could potentially refer someone or get advice so that you can give the appropriate care. I do think it's something that we should stand up for and find ways to address for our patients and families. So thanks, Chantal.
Yeah,
Thanks, Rick.
definitely, Erin. If I may add something, in Sanad model, for example, we created a sort of a referral criteria where the team, the basic team, nurses, doctor, psychologist, everyone that in the core team can provide generous level of psychosocial support. Where compassion listening, we cover the 4 aspects of care: physical, psychological, social, and spiritual. But at the same time, but at the same time, we created the referral criteria for people that they cannot benefit from a psychosocial support. They need more like a specialist intervention, because we know the impact of and the load of emotions that can the staff have as a secondary trauma facing this. Yeah.
Thank you.
Thank you, Erin, for your question.
Thank you, everyone. And thank you, Rick, for actually highlighting that actually an act of service can help you cope. And one of the things that we can do as a palliative care community is that we know that the need for opioids for pain relief, and it might seem just a small a really important aspect of palliative care, but we can join the advocacy voices. And it's so good to have Catherine Pettis with us here today, who's actually spearheading the advocacy for that with IAHPC. And that is something we can all take up with our governments. Make sure that any humanitarian groups going in from your country are taking with them adequate opioids, adequate pain relief. And we also all need to be highlighting the need to do training before the crisis happens. How do we do more community training so that people can at least do something to help with the psychosocial and spiritual aspects of the trauma that comes with a humanitarian crisis of any sort? And so a very big thank you to our speakers, to Father Rick, to Alexandra, to Jenny, and to Chantal. And to all of you who are here with us today, thank you for joining us. Thank you for being part of PalChase. If you haven't joined PalChase, please do and consider joining one of the groups. And the groups are advocacy, communication, education, and research. And just help us to spread the message that palliative care is essential in humanitarian settings. So would any other members of the exec like to say something before we close? And at the moment, Erin, would you like to tell them about the vote for advocacy that we are sending around on our social media?
Yeah, we are, we kind of work in quarters here at PalChase. We do quarterly webinars and we do quarterly newsletters. And we like to be very grassroots in how we allow people a platform to share about the work that they're doing. One of the ways we're going to get ready for our February newsletter is by sharing around a word cloud about morphine. So let me quickly share that with you now. And it's through Mentimeter. So you can add in 3 comments related to what you believe, what comes to mind when you think of advocating for morphine in palliative care. So let me just share my screen and you can vote along with us. Thanks for being with us today.
And if you have time, please, would you actually fill in the feedback form? It is very helpful if we have your comments and your feedback. So there we are, and you'll find it on our social media, I think on our website as well, is it, Erin?
We'll get it up.
We'll get it out there, okay. But it is on our social media platforms, and it would be wonderful. And Catherine, I think it's something that we can share with you that might be helpful as well. So thank you, everyone. Thanks for being with us. Yes,
Joan?
Catherine?
Can I just say very quickly that Pal Chase is represented at the WHO EB right now, and that we're advocating for palliative care in emergencies with some very strong statements.
That's
So
wonderful, and thank you.
Yeah.
And we will be sharing those statements as well. Moira Ling, who is on the executive committee, is representing IAHPC and Pal Chase at the moment at the executive board of the World Health Assembly. And so let's all, if you have nothing else, you have your voice. So let's use it wisely and have a strong voice for access to morphine and access to palliative care. So thank you all. And as you go forward, just hold in your hearts and in light our colleagues who are working in humanitarian crises of all different sorts around the world. We are with them in spirit if we can't be with them in person.